Hello, everyone, and welcome to today's webinar. My name is Michael Stevens. I'm a communication director here at Ramboll, and I have volunteered to facilitate the technical production of today's session. So if anything goes wrong, I'm to blame. And we already have 66 participants. We have a number of speakers and a video, so it'd probably be a miracle if it doesn't. A few words on webinar protocol. We want to sort of make this as interactive as possible. And we set up a few rules. If you move on, Mika, that would be helpful. There. So all of you will be muted from the beginning, and you will not be able to use your camera today. But we want to make it as interactive as possible. And if you have any questions, you'll see in the bottom right corner of your screen, probably there is a chat function where you can ask questions. And we will do at the end of each presentation, we will try to collect the different comments and do our best to answer them in good time. And if we don't answer them during the session, we'll try to follow up as well. It's just a second, I need to mute someone. There we go. What we will also want to do, we want to today, after today's session, we will record the session, sorry, and then we'll share with you after the webinar. You get the full recording, and you also get the different presentations, so you have your possibility to dive a little bit deeper in it. And at the end of today, we'll ask you, we aim for constant improvement, and we'll ask for your feedback at the end. And we have a number of different polls and questions we would like to answer during, get some insights from you. The topic for today's seminar is how infrastructure can play a role in supporting and improving resilience among healthcare workers, and how simulation and modeling can support us in assessing if our buildings can cope with the different stresses they are experiences. You can see today's session. Here's the the agenda. I'm Michael. I'll get out of the way in a second, and Mika and Jonathan will take over and get you safely through the day. We have from Sweden, we have Ulrika and Fredrik, who will talk a little bit about the Sahlgrenska experience. We have Julie and Deepak from NHS, who will give some UK flavor to it. And we have a video recording from the Queensland University of Technology. And we also have Jane, who will be able to answer some questions if there are. And finally, we'll end up in North America, where Kyle and Dan will show us some different modeling and simulation tools they have. At the end, we'll have some time for some Q&A. And then Mika and Jonathan will wrap the whole thing up. And once we're gone, once we're over, the whole thing over, I'll make sure that you all get a copy of the whole session. So before I hand it over to Mika and Jonathan, I would like for you to take out your telephone and try and go to this poll. Go to menti.com and use the code 8645449. And that way we can answer the question and what kind of organization you are. Then we can get a sort of some sort of insight in who is interested in the different topics and how we can actually tailor it to the different people. So please go to Menti. We have a little sort of short break, and then we will quickly move on afterwards and introduce you to the topic. Great. As mentioned, we have now 83 attendees, so there's still a few people who have to find their phone and try to identify where they're coming from. And for all of you, keep the phone out, because we'll try to do a few more of these polls during the whole webinar. So we'll just take a minute. Fairly evenly distributed. Okay. So I think we should now, we have, once we get to 50, I think most of you, we should have it there. Most of the people have responded. Okay, it seems we're at a standstill. 48, great. I will now hand it over to you, Mika and Jonathan, and I don't know if this is similar to the distribution you saw at the last webinar, but maybe you can just touch upon that. Okay, see you later, and I'll be in the background. Hang on.
Great, thank you very much, Michael. As you said, I'm here with Mika. My name's Jonathan Erskine. I'm Executive Director of the European Health Property Network. I'm also a non-executive director on the board of North Tees and Hartlepool NHS Foundation Trust. We have 2 representatives from them with us today. I'll just hand over to you, Mika, just to introduce yourself.
Absolutely. So I come from this column here, this called consulting. I work as a change manager in healthcare, and I predominantly work in Sweden and Norway in actually improving the future healthcare buildings and align them with the organization. And that's a little bit also at the core of today's webinar. I'm Swiss originally, and as I said, I am now at the moment living in Sweden and driving our Walker project franchise here in Scandinavia from here. Around half a year ago, we started this initiative together with Jonathan and Fleming Schmidt from Ramboll in the beginning. What we actually saw is that in a very short time, surprisingly similar approaches emerged in response to COVID-19. In the middle is the so-called the original prototype from Wuhan, and if you look at these temporary care facilities, they all look very, very similar across the world. At the same time, we also saw that there are significant differences in the way they are used, and as well, already in the first webinar, we saw also approaches that said, no, we don't set up an external facility, so we don't relocate our care, but we rather reorganize our care facilities or reorganize our staff. And that made us curious to actually see, okay, what can we learn from each other, to collect different case studies, to compare them, and to also synthesize the findings. And that's what this project is about. Jonathan will say a little bit more about that in just a moment. So it's really about facilitating this learning process. And along the way, we had the pleasure to actually, together with the European Health Property Network and Ramboll, to also welcome white architects on board. So as you can see, it has become a pretty Scandinavian initiative, but through the European Health Property Network, we are very happy that we seemingly can also spread it beyond Europe and even further. When I look at the participant list, also at this point, thanks a lot to the financiers of this initiative. It's the Ramboll Foundation in Denmark, the Forum Vårdbyggnad in Sweden, and the White Research Lab. These 3 are very important, so we can make this initiative happen. So our goal with the project is really to collect, sort, analyze, and share knowledge, mostly from what have acute hospitals done in the first wave of COVID-19, and we really want to focus on what made them more or less resilient during that time. We call this approach compare and contrast, so we don't only want to find similarities but also differences, also be mindful of the context, and really deepen the understanding of the choices taken by the leaders. And we have a pretty broad perspective on that, from design, engineering, processes, and planning, and these are also the competences that are represented in the project team. We talk about resilience. It's a word we hear a lot about, and before we start, we just want to kind of share a little bit with you how we think about resilience. And we took a pretty broad and basic definition of resilience, really to think about the capability to maintain and to adapt critical functions when faced with changes. So our wish is also that we can actually learn beyond this specific COVID-19 pandemic, and also actually make a more general learning synthesis also for other changes or external shocks that are underway. We will look a little bit, okay, how have we prepared the organization or the buildings? How did we protect infrastructure and staff? How did we respond more concretely? How did we decide And also now, especially in the phase we're now, where some countries are for now in a recovery mode, and see also how do we go from an emergency state into a new normal state, so the recovery phase. And you will see we have a couple of webinars planned, and we have actually 4 topics, the 4S of our project. It's staff, where we will talk mostly about the psychological and the organizational resilience. So that's kind of independent of infrastructure. Then systems, where it's a lot about business continuity and critical functions. Space, where we will have a seminar on the 16th of October, where it's about the robustness, the flexibility, and the adaptability of the space. And also take a broader stance on supply chains. So what can we actually do in terms of ecosystem performance, where there we will take a transnational or even a global perspective on resilience. So resilience is really what all these case studies are circling around. And Jonathan will now take over and explain a little bit what we're concretely doing.
Yeah, thanks, Mika. I'll ask you to drive the slides if that's okay. As Mika outlined, we've got a number of webinars. We're also doing some other work behind the scenes in gathering case studies. We already had one in May that some of you may have attended, which was a kind of general view of the spectrum of response in the hospital world to the challenge of the pandemic. Today is all about leadership, staff resilience, and simulation and modeling to help prepare for the future and help give staff confidence in the way that we're prepared. And as Mika said, we've got a couple of upcoming seminars in October and November, and we'll remind you of those towards the end. So if we could go to the next slide, please. Yeah, so what we're hoping to get from the project, apart from the outputs from the webinars, are a number of things. First of all, we're planning what we call a field guide, which is in essence gathering together as many case studies as we can from across Europe and beyond, which are real cases of how hospitals and other healthcare organizations have reorganized themselves in the light of the COVID pandemic. And we're going to synthesize those findings, write some material around that, and keep it interactive and dynamic on a website that will communicate to everyone who's attended these websites and beyond. And in essence, this is for senior managers, policymakers, and so forth. Yeah, if you could just go back there, thank you. Hospital planners, obviously, and political stakeholders as well. I think we've already alluded to what the building blocks are, the challenges, the processes, the solutions, and the outcomes. So if we go to the next slide. Thank you. Yeah, this is just to note that we've already gathered around 40 case studies in some detail, most of them from Europe, but we're adding to this all the time. The project's going on at least until the end of this year and into next year, so I'm sure we'll gather many more. And at the end, we'll come back to you and give you some ideas of how you could contribute to that effort. I should possibly at this point just point out that this is a non-profit effort, and we want to make as much of this knowledge public as humanly possible, subject to occasional issues of confidentiality, but it's going to be out there for everyone to use. Okay, next slide, please. Yeah, so this is how we're going to engage with you. We would like you to take part in future webinars. We're going to ask you what you'd like to focus on. You can, of course, submit any case study that you wish in the field, and we'd welcome your challenge. We'd like to know from you what you'd like to see, where we should focus, and where you disagree with some of our conclusions. Next slide, please. Right, so today's focus, as we said, is on staff and resilience, leadership, the strategies for decision making, and encompassed within that, of course, we have our colleagues from Promodel who are going to talk about the issues of simulating the future and trying to look ahead as to how we can best respond. Right, next slide, please. I think it's about time to pass on to our colleagues from Sahlgrenska who take over from this point and give us their presentation on what's been happening at Sahlgrenska University Hospital I believe the largest hospital in Sweden. Over to you guys. Thank you.
Thank you very much.
Here we go, Falek. There we go. Here's your sign. Sorry for a little bit slight delay.
Yep, I will just like this. Do you see me or my screen?
Yes, we see both you and the screen, Falek. It looks good.
So everything is
Both of them.
okay. The only issue is I don't see my screen. Here it is. Thank you. So thank you very much. And here is Fredrik Sundeus from Västra Götaland region, and I'm real estate manager for the Sahlgrenska University Hospitals, part of the organization Västfastigheter, Real Estate West. And I'm sided here with Ulrika Wallander from the Sahlgrenska University Hospital, and she's resource planning manager. A little bit about where we are. As we said, we are in Sweden, in the region of Västra Götaland, which is located to the west of Sweden. And the region itself is divided in 49 municipalities with 1.7 million inhabitants. And the main city is Gothenburg, which is about a fourth of the population, a third to a fourth. And it's one of the three biggest regions in Sweden. There are in total about 20 to 21 regions. In the region as such, there are 18 hospitals, and the region is a political organization with the regional parliament, and these 18 hospitals are organized under 5 political committees, just to grasp the content, so to say. During this pandemic that we still are in, the Sahlgrenska University has treated over 2,000 patients with COVID-19. And in ICU, there were a peak in the beginning of May of 52 patients. Also some other numbers, 1,300 employees were very rapidly trained and retrained to work with directly with the COVID-19 care. Of course, this put a lot of stress on the hospital organization as such, and even the also real estate organization. And just to give you some more background, that as said before, the Sahlgrenska University Hospital is Sweden's largest hospital, and actually consists of 5 hospital sites in Gothenburg, and has a total of 17,000 employees. Västfastigheter, the real estate organization, are responsible for the property facility investment project management, and we are totally in the region 600 employees. As this is a political organization, there is also interesting organization and line of command, so to say, which start up at the regional board with the crisis management board through a number of different teams and special management out to each committee or regional company which had its own crisis management. And the focus on this crisis management organization was the intensive care sites, material planning and drug planning, intensive care equipment, travel planning, and planned care and supply of staff. And the basis in the Sahlgrenska University has been the epidemic plan that was adapted and also changed during time when this occurred. We quickly, when we started this work in March, when it took off, so to say, there was a lot of very local initiatives, very in the hospital and along our staff. So we quickly realized that we need to get some kind of agile organization between the hospital and the real estate management. And I would say quickly we set up a structure with very agile meetings and implementation of changes of the hospital. If we look on what we did in practice for the hospital, we one thing that was very early put in place was the triage of patient at the entrance. All in all, we had an infection clinic and 9 emergency care clinics where we put up these triages. The solution was rather simple and very straightforward. It was basically made by using containers or tents, and the main solution was actually containers, which was quite rather robust. Also focusing on electricity and gas and ventilation was part of this. Since we changed the logistic of the hospital's signage was a very important thing, because you had traffic that was running normal routes that suddenly couldn't do this. So that information part was very important. As said before, all the 5 hospitals closed its entries, and to be able to enter the hospital, you had to pass an entrance host, and where you checked for visible symptoms, and if you were symptom-free, you were admitted into the hospital. And one consequence of this, as we as a real estate organization saw, was of course that all the commercial shops, etc., inside did suffer or still suffer a lot of this business loss, so to say, which is perhaps in the content not so important, but it's important for the operators, of course. In the operations at the premises, what we did was that we created quarantine receptions and departments in the hospitals. We did screens for reindeer and infections side by side in several locations. Ventilations adjustment, also very important. Overpressure, under pressure, neutral pressure, and oxygen availability, also a very big focus point and complicated issue in some places. We also created more local storage for the care people, so that they didn't have to access medical goods and had it very close to avoid too much movements in the hospital. Reduced planned activities in the care and hospital, and we closed departments, and we increased mortuary places, and for that reason we used external refrigerated containers. placed at the hospitals where needed. How did we then change in the operation in the premises? And intensive care units was, of course, the main challenge. And physically, we created in 3 of the 5 hospitals 90 new intensive care units, in addition to the 59 that are already permanently placed at the Sahlgrenska University. The focus and the objective was to place the intensive care units in as large rooms as possible in the hospitals, with the target of 8 patients in each room where it was possible. And for this reason, we used pre and post units and bed halls. This required a lot of oxygen piping for the increased need of oxygen to the patients, and also power was there was a bigger power need, electrical power need, and ventilations. At one of the hospital, the East Hospital, we also put in a field hospital. Picture of some reason called the Crown. So there was actually two field hospitals, one with intensive care units with 36 intensive care places, and also for another field hospitals with normal care units, 42. And as the result was actually that the intensive care field hospital was used for patients, but never the care field hospital. And it was used during the peak part of the pandemic here that we had. This picture here is a good example of the agile handling of to try to find solutions. This is a staff sampling, which actually a little hut for bicycles in normal days, but it was upgraded to be able to take samples of the staff and to be able to give the response within 24 hours and to get people back on duty, so to say. Other COVID-19 actions that we looked upon, crew was of course big question, even if it not part of the real estate part, of course. Quick expansion of lab analysis equipment and installation. We had to adjust the ambulance transport and roadblocks. We had to change the flow. The Red Cross also put up crisis management tents on the different hospitals for potential of for patients and the relatives to them to be able to have find comfort if needed. We also looked into a lot of other potential measures at the hospitals and had plans to even increase the ICU places, doubling that, but that was never needed. And there were also some other pre-studies for different actions at the hospitals. And of course, as we were part of the region, there was a lot of interactions with the other part of the regions for additional ICU places. What was the toughest challenges? Staff and crew, of course. training, how to train the staff to adapt with the ICU and COVID-19 care, and to relocate staff from their normal duties into these needs. Ventilation and gas supply, as I think everyone has the same experience, and some medical technical equipment. We also were a bit worried at the time that the piping components for the medical gases would run out. Of course, the whole world was looking for these components. More management thing that we saw was that the crisis management had quite a very short time from decision to execution of adaptation at the hospital. So normally we get an order in Friday afternoon, and it should be finished on Saturday or Monday to alter the different care units. Good example of agile project management, I would say. And then also how to take care of all the rapid knowledge buildup that we had around COVID-19. I mean, we are one part of the region. In another part of the region, they also learned a lot, but how to communicate and learn from each other. Something to think of the future if we have these kind of quick situations. Success factors, and I think you all have the same experience, but you could get a little bit tearful when you think of all the commitment of everyone. I mean, in the hospital organization, but also in the real estate organization, how devoted people were to solve this. It was enormous to see and to be part of that. Then we also think that what we saw, Ulrika and I, that we quickly, from our part of this pandemic, with the coordination structure between the hospital and real estate, that we got up that quickly in place and very agile to care and took in information of the needs and also put it out to solutions in the hospital. We are, as I said, public funded organizations. So normally financing is a big issue. Here we did not have this question, but we have to take care of it now instead. And easy and quick implementation, partly due to the commitment of the employees. How to go further then? We still are in the situation, of course, even if the volumes are much lower than in spring. We need to find what we see now on year of focus is have more permanent or semi-permanent solutions, and one obvious one is the triage, and you saw our solutions. They are good for the summer half of the year, but not in the winter here in Sweden. We need to have a continued and easy sampling for the staff, and in the premises and in the hospitals that we have make it easy to have to be able to have people to keep their distances. And there is a need to continue to have extended capacity with the mortuary. And by these words, we would like to say thank you, folks, and that's all. And if you have any questions, please feel free.
Thank you so much. Really fascinating presentation. I've been keeping an eye on some of the questions that have come through, We don't, as you know, it's quite a tight schedule that we've got. So I'm going to try and sum up a couple of those questions in one, if I may. You mentioned some of the effects on staff, some of the training. Someone asked a question about that, whether the training is going to continue into the future. So staff are going to keep those multidisciplinary skills that they may have developed. And I'm just wondering, how have staff reacted to that? And I'm thinking both of the clinical staff, but also the non-clinical, the staff who work in estates and work with the facilities and may have had to work differently. How have they reacted, and will they continue with the same behaviours in future?
I turn myself to Ulrika, who is closer to the. Oh. Yes, hold on. That there will be continued education and training of the staff who has been with this multi-purpose or multi-skills knowledge. And I would say in the real estate, of course, we need to consolidate the knowledge that we build up within the region, but also within Sweden, between the regions. Because there are a lot of experiences, and we will look into the future and how to convert this for crisis management of different kinds, not only a virus pandemic, but there is also other risks that has increased, not even medical risks, but other risks.
Yes.
So to say, yeah.
Yeah, that's a very good point, I think, to end on, and I hope we can continue to collaborate and share those experiences with you. Thank you very much for your presentation. Thanks.
Thank you.
I'm now going to ask, I'm not sure if it's Mika or Michael, but whoever can now turn us to our next speakers, who are Julie Gillen, who's Chief Executive of North Tees and Hartlepool NHS Foundation Trust, and Deepak Dwarakanath, who's the Medical Director and Deputy Chief Executive of the same organisation. So I'm hoping that we can pass over to them now.
I think we can. I've given Julie. Yep. There you are. We can see you. Perfect. The screen is yours if you want to share it as well.
Okay, hello everybody. My name is Julie Gillen. I'm Chief Executive of North Tees and Hartlepool NHS Foundation Trust, and we have Deepak Dwarakanath just sitting behind me, who is our Medical Director and Deputy Chief Executive. I would like to welcome you all here today to showcase our experience of COVID and also our leadership approach during the COVID pandemic. Just a little bit of an introduction to the Trust before we just go through the presentation. We have around 550 beds in this Trust through over 3 hospital sites. We have 5,500 staff, and we serve around 400,000 population, and that is with screening services for bowel and breast screening, but also for general and acute and community services. So we are regarded as a medium-sized general hospital in the northeast of England, and we serve some of the most deprived communities even before COVID hit us. So in this country, we are one of the most 10% deprived areas in the northeast. And in this particular area that we serve around Stockton and Hartlepool and parts of Durham, we are the 4th highest for premature mortality, and we have the most years of life lost in relation to colon cancer, stroke, and pneumonia and lung cancer. So we are serving a very, very deprived population, and therefore we knew the incidence of COVID would hit us extremely hard. And just thinking about the previous presentation, just a little bit of background around how we are regulated as an organisation. We are regulated by NHS Improvement and NHS England, and we are, certainly myself, I'm accountable to government in terms of how I run and manage this organisation. So we have several bosses, I'm sure you're all used to that, but we have several bosses, and this became very evident during the period of COVID. So within the overall topic for discussion today, Deepak and I wanted to concentrate on a number of key aspects of our response to COVID, and in particular our leadership approach, and how we managed our governance approach in terms of our operating models, and how we empowered our clinicians to make decisions and to have the foresight of recovery and restoration at the back of their mind, even during the peaks of the pandemic. And the thread that's running through our presentation is that enduring compassionate leadership, that empowerment and support for our staff, and that real cultural bedrock that we've created in this organisation to enact change and to learn lessons. So just in the words of Heraclitus, who's a Greek philosopher, the only thing that was ever constant during the period of our COVID response is the need to change. And with that came very much a vulnerability of leadership, and very much a lack of certainty as to how to make decisions. But what we want to do in the spirit of our culture is actually empower and enable authority amongst our clinical and managerial staff to make decisions where they were interacting with patients. And to do so, we learned lessons from what had happened across the world. So we know that during the period of December, there was the outbreak declared by WHO and the etiology of pneumonia in Wuhan city. And we needed to learn a lot of lessons. And I think from that, as leaders, we know that we didn't get as much information that was coming out of other countries. And I think that's something certainly to learn from today's exercise as to how we actually create that avenue to enable learning to occur at all levels. Okay, just as I was saying, we had our first recorded COVID case in the UK at the end of January, and we had our first case in North Tees on the 3rd of March. That gave us an opportunity during February to start to prepare for what we knew was the inevitable pandemic peak in the UK, and to think about how we could be adaptable and versatile to change our estate, to change the way we operate, and to enable staff to develop the skills to accommodate the change in etiology that we were expecting. We had our first COVID death in March, and then we worked towards how we managed our urgent operations, and all non-urgent operations were actually cancelled in March. And that's a lesson to be learned, I think, for ourselves and as leaders, that during that period of time, we understood the magnitude of the requirement for recovery, but we didn't expect the need to recover so quickly. And I think towards the end of March, we put our first patient into randomised recovery trial at North Tees. And I know Deepak is going to talk about the immense amount of lessons learned and the clinical decisions that were made to actually enable us to treat our patients very differently and to ensure that we improve the outcomes of our patients during the period of the pandemic. So just thinking about what drove our decision making during the period of the pandemic peak in particular, we could easily have gone into a command and control type of situation, and certainly the government and NHSI and Improvement and NHS England adopted legal rights to enable command at the centre, which meant that there was a lot of competing and conflicting information, both from our centre and from our Public Health England colleagues. We resisted the temptation to go into command and control, and we relied on our tried and tested methods of leadership in this organisation. We developed a balance of understanding where our clinicians and our managers were coming from. We didn't adopt the authoritarian style or the top-down approach. We actually enabled our leaders through a series of cells, and I'll come on to talk about that, to have delegated responsibility and delegated authority to make those decisions, and to empower our clinicians to actually work towards effective and improved decision making. But our true north in terms of our decision making, our focus was very much about, which led our decisions, which was very much about how we actually managed patient safety at all costs and how we managed our staff safety to ensure that we made the right decisions at the right time during periods of very complex information flows and very complex and unconventional methods. Just moving on a slide. The one thing that was very set in our mind was the illustration from certainly USA studies around how culture and empowerment and delegation actually saved lives, and that quality improvement should drive the way you make decisions. And we very much illustrated that by relying on our clinicians and our managers to escalate any issues by variance to the executive team. Moving on, Michael. And what we did therefore was we developed what we called leadership cells. And the executive team, which is our directors and myself, met twice weekly. We had strategic command, which met in daily meetings to ensure we had a coordination of all of the decisions and the impact of decisions made in other cells, what that impact would have on key decision making. For instance, oxygen delivery, what decisions made in oxygen delivery would have upon the way we treated patients in our clinical cell. And we developed tactical cells, 6 cells, clinical decision making led by our medical director, infection prevention and control, and we had to make a lot of very, very clear decisions on our personal protective equipment to make sure that our patients and staff were safe at all times, given that there was a national shortage of PPE. We made estate changes very quickly, and we made oxygen delivery and oxygen development changes very quickly throughout our cell. We had planning, intelligence and recovery very much from day one as a cell, so we were looking at our data and understanding the intelligence that drove some of our decisions, specifically around outbreaks and specifically around conversion to critical care requirements and of course ventilatory requirements. And we had a communications and advisory cell which helped us to publicise our information and give key messages to staff and to our board of directors and to our council of governors to enable us to ensure that everyone was kept informed during a period of social distancing and lockdown. Moving on, Michael.
Thanks, June. Some of the challenges we faced during COVID are on this slide. We live and work in a building that was designed and built in the 1960s with a very rigid structure. Our intensive care capacity and our respiratory infrastructure was finite, as was our oxygen delivery capacity. We were asked by our peers within the region and nationally to look at our surge capacity for intensive care. We normally have 17 beds in intensive care for both HTU, non-ventilated patients and ventilated patients. And we worked out scenarios to go up to 24, 25 patients, up to 40, and in almost an Armageddon situation of potentially up to 80 patients. We obviously had to look after our staff. As Julie said, we have 5,500 employees doing various hundreds of different professions to make healthcare possible, and it was ensuring that our staff were kept safe as possible throughout this period. And together we have to also think of the mental stress that would be that staff at the front line would be undergoing. The other difficult decision for many clinicians was the ability to triage patients at the front of house to decide what levels of care were appropriate in the scenario, in this particular scenario, with a disease we knew very little about. The flow of patients through the building was obviously critical to make sure that patients without COVID, who didn't have COVID, were not infected with COVID, and that again put a huge stress on our 1960s building. And as Julie's mentioned, the IPC, the infection prevention control decisions were very, very critical. The National Health Services during this period very much became a top-down organisation. So from the centre, from London, we were literally getting 10 to 20 missives a day to deal with going across the whole trust. Next slide, please. So we really, this just illustrates some of the challenges we face during this period. As a doctor, we had no previous knowledge of this condition, and this is probably the first time in my professional career of nearly 35 years where we knew nothing about something. We were relying on information from China, Italy, and Spain to decide how we could treat patients. This was just new territory. At that stage, back in March, we had no effective treatment apart from intensive care support and oxygen delivery, and there was no signs of a vaccine. We rapidly developed the knowledge from our peers in the UK that CPAP, continuous positive pressure airway management, was very critical, and also turning patients upside down so they were face down on ventilators was also a critical decision. The other thing that we realized quite rapidly and throughout the UK was that these patients were very prone to get lots of blood clots going to the lungs. They were very prone to pulmonary embolism. So the levels of anticoagulation that we normally use in patients in this situation had to be raised. And the other important issue that Julie's already mentioned is that the only way that we were going to help both nationally and internationally as an organisation to fight COVID was to enrol in as many trials as possible. And one of our important decisions was not to step down our research department during this period. They were fully activated. They literally ran through the trials. As soon as they came from the national organisations, we signed up to join them. One of our successes was the so-called Recovery trial, which was a multi-limb trial to look at various treatments. And we're proud to say that for a size of trust that we are, with the number of admissions that we have, I think we were in the top 5 recruiters in the country. And as I'm sure many of you know, at least 3 treatments of COVID have come out of this. Obviously, our existing HDU and ITU staff could not stop staff of an expanded unit, and this meant staff from other parts of the hospital, particularly the theatre staff, was skilled up rapidly over a matter of days on basic intensive care nursing support. This is phenomenal. You know, people suddenly dropped what they normally do, changed their whole working pattern, didn't mind going from normal shift patterns to 12-hour shifts, 7 days a week. We also became aware within days one of our biggest risks was that any of our precious staff could get infected with the virus, despite all the PPE and all the IPC protection that we could offer them. Unfortunately, a few members of staff did become unwell during that time, and we're very pleased to say that none of them did succumb to COVID, which was obviously a huge plus to us. Obviously, our respiratory teams worked with our estate teams to look at the oxygen delivery, as has been already mentioned from our colleagues in Sweden. We had infrastructure that was built for 1960s type medicine, the 1970s type medicine. We were using oxygen at a much higher level of flow and concentration than had ever been experienced. And we calculated literally within days that if we had 2 patients on high flow CPAP, it could actually use the oxygen supply that would normally be sufficient for 60 patients. This really put an enormous pressures on us as clinical decision makers, together with our estates departments. We're very proud of the fact that within a few days of us thinking this through, we have a sister site 15 miles up the road in Hartlepool, and with the help of the BOC company, we moved the oxygen storage tanks from 15 miles away, piped them into our system here, I think over a 4-day period, and that almost doubled our oxygen capacity and ensured that oxygen was no longer one of the issues for us. Those of you who are engineers on the line will realize that the flows of oxygen that we were using at that time meant that there was a great danger of the pipework freezing, and we had a team of young men literally hosing down the pipework with warm water 24/7 for weeks on end to ensure that that didn't happen. As you can see in the bottom right-hand corner of this slide, this was our ability to look at oxygen delivery across the whole trust so that we could say, right, in this particular area, it was safe to move a patient who needed certain high flows of oxygen and things. Next slide, please. So the clinical aspects that we learned, and I think has been internationally recognized, that patients with diabetes, patients with obesity, with BMIs over 35 really had a significant risk of death from this condition. We only had one death in the under 55s, and unfortunately this is a condition that is worse as you get into your 60s, 70s and 80s. Prophylactic high-dose anticoagulation was critical in keeping our mortality rate down. And interestingly, as we look back at our performance, the deaths that occurred were in the end of March and going into April. We virtually had no deaths beyond that point when we changed some of the treatment regimes that we were using. Obviously, multi-organ failure was an issue, and around the UK, renal replacement therapy was an issue, and we came to the point, from a supplies point of view, as a country, of running short of some dialysis fluids. Inflammatory proteins such as ferritin were a good marker of poor outcome. The one thing that we were worried about is, as we got busier, was our care dropping off? Were our outcomes worsening? One of the things that we have been reassured by, that when we've looked at occupancy in the extended intensive care, which went up to nearly 50% of its normal, 50% on top of its normal capacity, we did not see an increase in death, and that was reassuring with regard to the quality of care we were providing. Next slide, please. This, as you can imagine, was, both myself and Julie have worked in the health service probably for a combined 70-odd years, sounds a long time. And this is an incredible intellectual stress on the whole trust, but more importantly, it was an enormous emotional stress. This is, as I said, a set of conditions and outcomes that we were not used to. Patients were having to be triaged. We're having to look and see whether a patient would be appropriate to go to high dependency or ventilated. And I'm pleased to say that we never, ever in this hospital, and I think throughout the northeast of England, came to a point where we had to decide on whether patient A or patient B would have the last ventilation in the hospital. We've got an excellent intensive care network in the northeast, so if we ever got to a critical point with regard to the number of intensive care beds that were available in a given trust, patients were moved around. The other issue was we were still getting admissions of normal illnesses, and we had to ensure that those patients weren't disadvantaged at any time, even through the peak of COVID. And as I said, it was a lot of our initial assessments of patients was prioritizing to ensure that everyone got the best possible outcomes. Next slide, please. So some of the things that we did really was, and we still are continuing to do it now, is really watch our colleagues and friends. It's surprising, people that you know really well can react really terribly in such stressful situations, and I'm sure that this could happen for years to come. It was really very, very important that we ensured our staff were kept safe, as was the case in many countries throughout the world. PPE was an enormous issue, and our chief executive was on the phone throughout the weekends and through the nights to ensure that we had a safe supply of PPE, which, to be honest, when we now go around the wards and talk to our staff, they're eternally grateful. We never came to the point of running out of PPE. The other important thing was, as I said earlier on, people's shift times and shift patterns changed, and we had to create new types of rest area both within the trust, and we actually hired a top style bus. So when pop stars go on trips around the countries, they sit in very nice big double-decker buses full of lots of nice comfortable seats and places to lie down. So we had that as a recharge bus full of nice little snacks and things that people could go to, and that helped. We obviously upskilled staff and helped to support them through there, and we ensured that there was mental health support right at the front line. People didn't have to ask, it was there. So we had our clinical psychology team on site and working around the hospital. The other thing that sadly we realised very early on, that some patients with COVID literally came in and started to deteriorate despite our best efforts within hours, and these patients could go on to die within 24, 48 hours. And this put a huge stress on the ward staff, and we ensured that our specialist palliative care team were there, obviously, to ensure that the patients had the best possible end of life care, and also ensure that our staff were well cared for. It was very important that Julie, myself, and other members of our executive team were visible and were willing to listen to the cares and concerns of our staff, and that was very important. We've also gone on to develop use an app called Listening in Action, and this is an instant way from your smartphone that staff can give us feedback as required. Next slide, please.
Just Deepak, thanks a lot. It's really interesting, but also in regards of having good timekeeping, it would be good also if you can try and get through this in 5 minutes, then we have time for some questions.
Absolutely, yeah. Okay, just in terms of lessons learned and an operating model for the future, we don't want to continue to reflect back and stay in the same static situation that we had during COVID and prior to that. We want to move on to look at how we transform for the future and what our operating model will look like for the future. So one thing that we've learned during this period of time is that not only did our outdated estate pose a major risk to ourselves and to our patients that we managed and mitigated, but we now need to think about how we manage patient flow for safety reasons and infection prevention control reasons. We've received 3 million in capital to manage the infrastructure of our front of house with one single entrance and one exit, and we can manage the flow of COVID and non-COVID patients. We have learned that we need to now manage patients very differently in our remote areas. We have a very low car ownership in this part of the country, and we wanted to make sure that what we did during the period of COVID, we can continue to do around virtual engagement with patients and virtual case management with our primary care colleagues. We have offered our hand of help to our social care colleagues to ensure we can discharge and manage our flows appropriately in hospital. And we've actually turned around the way we manage patients from a same day to a daycare within another part of our hospital, our sister hospital 15 miles away. So we're utilising our capital differently, we're utilising our estate differently, and we have learned that by being early adapters and early adopters of change, that we can continue to transform our operating model. Next slide. One of the key issues for us going forward is to how to balance our COVID-19 flow and living with COVID-19 and our business as usual. And at the moment, we're very much weighted towards COVID-19, but as things get back to a degree of normality, we want to move to the centre left, to business as usual, but we do not want to underestimate the need for transformational change in our estate, in our workforce, in our engagement, in our culture. We are now adopting different ways of working around clinical triage, around our waiting lists. We are making sure that the clinically at-risk categorised patients are brought into the organisation as a priority. And we're now managing different ways of working through digital enablement. Move 2 slides forward, Michael, in the interest of time. And this is our digital enablement offer and what we have done during COVID and beyond. So what we are looking at now is the ability to adapt our virtual suite, our virtual methods in order to manage patients and staff very differently. So we have different virtual capability now. We have Attend Anywhere for our patients, and we're now developing digital hubs at our alternative sites, so we do not have to have patients coming to our acute site. We have virtual visiting for those relatives who cannot come into and travel into our organisation and are at risk of COVID. And we have remote monitoring and surveillance of our patients to minimise that contact and that airflow around our patients. And they're just some of the areas you can see there are a number of areas around our digital offer, but we are certainly now moving forward with our digital strategy at pace. Moving forward. Our approach
is really to ensure that if there's a second wave, that our staff don't get infected. We've got to constantly review the management of patients throughout as more trials come on board. Staff well-being will be a long-term issue for us, and interacting with regional teams both in intensive care and respiratory medicine has been important. All trusts, all hospitals throughout the UK and throughout the world have strengths and weaknesses, and it's important that we recognise that. And the other important thing is support, and one of the great things of our organisation is mutual support.
And moving on a slide. We'll make this our last slide, Michael. And just to summarise on our approach, this has been an extremely difficult time. I don't think that we thought that the NHS could adapt very quickly, but we have shown that that can work, both in our treatment of patients, but also in our ability to lead in a different way. We wanted to make sure that our compassionate leadership remains appropriate and that we delegate appropriately to our clinical and managerial staff. And our culture of learning, risk-taking and empowerment has certainly paid off in the successful way that we have managed COVID. But the one thing that I will say in terms of the whole of the executive team and the whole of our leadership was that we tapped into the intrinsic motivation of our staff, and that was to ensure that we remained patient-centric and our patient safety was our priority amongst our staff safety. Thank you.
Thank you very much for this. Thank you very much for this presentation. This was spot on, I think, and touched on a lot of topics that we had hoped for. We would have a debate about today. In terms of question, there was a question around there was new decisions needed to be taken, also from the leadership, but also from your staff at the front line. And the question is, yeah, the prioritization between patients. All of a sudden, you have to do prioritizations that you usually not have to do. How did you support your staff with that, and how did you kind of carry that as an organization?
As you said, this was an absolutely important part of our management of patients. We use nationally recognised COVID scoring to see what levels of escalation were appropriate in a given case. But we also ensured that it wasn't down to one particular individual to make that sort of decision, because obviously that can weigh heavily on someone. And there was always a team approach, and there was no problems with getting a second or third opinion and making sure that that decision was well supported and discussed both with respiratory colleagues or intensive care colleagues.
Thank you so much. A second question, many people say, well, this crisis has of course been kind of a test for many organizations, but it also has to be kind of been a supercharger in terms of development and kind of as well, when you think about how the way we work together digitally, you mentioned it, how you communicate with your patients. You as a leadership team, how did it kind of evolve the way that you work together, and what you have learned now throughout the more acute crisis will you kind of take forward?
Certainly from my perspective, I think the way that we have learned to work together, and this is about trust and relationships, is that we can make decisions and we trust each other to make those decisions on an individual basis and bring back the rationale for change, for why we've made those decisions. And creating that supportive environment, as Deepak mentioned, not just at clinical level, but at managerial level. Because if you can rationalise your decision and think it through as an individual, you can rationalise your decision to anybody externally and to a patient. And that is the trust and relationship we've built during this period of time. that the focus wasn't on any one individual, but they could bring back and challenge any decision that was made. But because we had to make decisions in a crisis situation, that we had to know that we had to rationalise that decision based on intelligence and based on evidence. And it was that intelligence flow and evidence flow that enabled us to rationalise appropriately. So we will take that forward into the future. And what our staff would ask for is that we cut out the bureaucracy of governance, although there is a place for governance and decision making and responsibility, but that we cut out the bureaucracy and we continue to make decisions in a very quick manner, but again, by supporting individuals to make those decisions.
Thanks so much. This is impressive. Jonathan?
Jonathan, you're on mute.
I've just been unmuted. Thank you. Yes. Well, look, I'm not going to add, in the interest of time, I'm not going to add more to that at the moment. Thank you both so much for, I would say this, wouldn't I? Fantastic presentation, but it really was. I think what we've done is we've looked at the real world experiences of two organisations now. You both, Sahlgrenska and North Tees and Hartlepool, have begun to look at how things might change into the future. And in the second half of this webinar, we're going to look further into the future. First of all, through a video from colleagues at Queensland University of Technology, which I think is self-explanatory. So if Michael or Mika could run that video now, it's about 14 minutes long. So I'm not sure if there'll be opportunity to ask questions, but then we'll move on to our presentation from colleagues in the USA at Promodel. Thank you.
Good morning, good afternoon, good evening. Whatever time it is when you watch this, I'm delighted to be with you. I'm Yvonne Miller, Professor of Design Psychology from Queensland University of Technology in Brisbane, Australia, and I'm joined by my colleagues, Dr. Lindy Osborne-Burden and Jane Carthy, to talk about some of the research we're doing at the moment about redesigning hospitals for the future. So our project, From Admission to Discharge, designing biophilic, salutogenic, eudaimonic hospital spaces in a post-pandemic world. Just a brief definition: biophilic, of course, is about nature, salutogenic is about health promoting, and eudaimonic is about designing spaces that promote happiness. I'd like to acknowledge the Turrbal and Yagara as the First Nation owners of the lands where QUT now stands, and pay my respect to the elders, laws, customs, and creation spirits. I recognise that these lands have always been places of teaching, research, and learning, and that these lands were never ceded. I also acknowledge the important role Aboriginal and Torres Strait Islander people play within the QUT community. So today we'd like to talk about HEAL, the Healthcare Excellence Accelerator Lab. This is a partnership that just kicked off only 2 weeks ago between us at the QUT Design Lab and Clinical Excellence Queensland, part of Queensland Health. And the focus of this partnership is really just to re-envision and redesign healthcare. As I said, it's a partnership between healthcare and the design community. And the project is designed to be a bridge between the QUT design and innovation community and Queensland Health to accelerate healthcare improvement across the state. We'll connect healthcare practitioners with designers to work together and use design approaches to transform thinking, spaces, places, processes, and products, and positively transform healthcare. It builds on a long-standing partnership that we've had with Queensland Health, particularly Clinical Excellence Queensland, and that was cemented last year. We had a week of activities as part of QUT Design Week, and we came together and collaborated and brainstormed and talked about what our ideal vision was, and we held a number of design thinking workshops around an array of projects. So just briefly, a little bit about the QUT Design Lab. We're a research centre that's focused on change by design, basically, and we've got 3 key programs: designing for health, designing future technologies, and designing creative and resilient communities. And we see this partnership between designers and healthcare community as a catalyst for really changing how we deliver healthcare. And we intend to use design to intentionally kind of challenge and provoke and to rethink how things are traditionally done and to stretch those boundaries and work together to tackle those wicked problems in healthcare. Now, as I said, we're just kicking off, and today we're going to talk about one of the projects, entrances and exits, which my colleagues will talk about. But a few other things we're doing include co-designing virtual health consultations, developing child-friendly personal protective equipment, looking at new ways to assess pain, resources for cultural safety, wayfinding and placemaking, and making that an enjoyable experience for children, and of course using VR and AR, so virtual reality and augmented reality, to enhance, you know, what's the experience of being in a hospital over an extended period of time for children in particular. If you want to know more, please connect with us. You can follow us on Twitter at QT Design, on my own personal Twitter as @Yvonne PhD, and just watch the space basically, because we've got a number of different projects that we would be delighted to talk about. But the first one is about entrances and exits, and Lindy will take on from here.
Good afternoon, everyone. My name is Dr. Lindy Osborne-Burton, and I am both an architect and an academic at Queensland University of Technology. The next part of the presentation, I'm going to provide you with some context around how we have developed our research project with the Sunshine Coast University Hospital. In 1933, the Finnish architect Hugo Elvar Hendrik Aalto and his wife Aino completed the Peina Sanatorium. This was a facility which was used for the treatment of tuberculosis and was situated in the southwest of Finland. The building, as you can see, is rigidly geometric. It has long walls of expansive windows which wrap around its facades, and light-coloured rooms, and wide roof terraces with railings, which are reminiscent of the ones that you see on cruise ships. All hallmarks of what we now know as modernist architecture, which emerged in the 20s from the work of the Bauhaus in Germany and Le Corbusier in France. Now, if you fast forward nearly 15,000 kilometers and over 80 years, you'll see that very little has really changed in healthcare design when you see those images of the Peina Sanatorium compared with more contemporary photos of the Sunshine Coast University Hospital, which was completed in 2016 in the Sunshine Coast, Queensland, Australia. As we are all obviously painfully aware, 2020 has seen the introduction of the COVID-19 coronavirus pandemic, which has fundamentally changed the way we live and we work. However, we must ask the question that what does this mean for the future of healthcare design if we are to learn to live with, or perhaps even eliminate, pandemics such as this coronavirus? The image that I'm showing you now are the sorts of images that the media is constantly throwing at us. And we're being told that we need to, in our workplaces at least, shield ourselves from each other by wrapping ourselves in glass or perspex screens. In urban environments, we're being told that we need to maintain safe distances between each other and preferably actually spend time with each other in outdoor environments, which are deemed to be safer than being in interior environments. So we think that perhaps we can do better. We can learn from the lessons of the past. We can learn from the architectures and approaches of healthcare architecture in the past, and think about how we can design a more integrated approach to healthcare architecture moving forward, particularly in the face of the coronavirus pandemic. Our proposal is for an integrated approach to healthcare architecture, which includes three main components. The first is biophilic architecture. So biophilic health architecture purposely engages with and integrates nature to help promote physical healing and to improve mental health. The second component of our integrated approach to healthcare architecture is salutogenic design. And salutogenic health architecture actively facilitates improved health and well-being rather than merely providing environments where illness can be treated. And the third component of our integrated approach to healthcare architecture is eudaimonic design. Eudaimonic health architecture inspires happiness and a deep contentment with oneself and one's life. And so bringing the three together, our integrated approach to healthcare architecture combines biophilic, salutogenic, and eudaimonic approaches. The graphic I'm showing you at the moment highlights nature's dialogue through layers of building envelope, multiple spaces, anatomical, sensory, and physiological body filters, ultimately having emotional, psychological, and physical impact. This next graphic shows us that sustainable practices do no harm, while restorative practices can heal some of the harm that has already been done. So we argue that regenerative design creates a cascading series of benefits instead of externalized harm. I'm going to be concluding my part of the presentation by showing you some examples of contemporary architecture in Australia, starting with the Translational Research Institute, which is located on the Princess Alexandra Hospital campus here in Brisbane, Australia, in Queensland. Designed by Wilson Architects and Donovan Architects in association with each other, and this building was completed in 2012. Just on the road in Sydney CBD, in Sydney, New South Wales, Australia. This project was completed in 2020, and it's the Darling Square and the Architectural Aspect Studios. The Puntukerni Aboriginal Medical Services, otherwise known as PAMS Healthcare Hub, designed by Knut Jung Architecture and completed in 2020, is located in Newman, close to the Pilbara in Western Australia. Also designed by the same architects, Knut Jung, and completed in 2018, is the Panu and Pangur Aboriginal Health Clinics, also fairly close to the Pilbara in Western Australia. Completed by Knut Jung Architecture in 2016, is the Bariki Aboriginal Corporation Medical Centres Clinic, which is located in Purfleet in New South Wales, Australia. And the final image I'm going to show you is the Wollumba Elders Centre, which is an aged care facility designed by Iredale Pedersen Hawke Architects, and this is located in Warram, Western Australia, which is fairly close to the Bundles. I'm now going to hand over to Jane Carthy, who's going to give you specifics of the research design for the project that we're proposing and commencing now with the Sunshine Coast University Hospital. Over to you, Jane.
I'm now going to give a quick overview of our current project. I realise that our time is short, but the other thing is that we've only just started the project and about 2 weeks ago, and we're just about to start gathering data for it in the next few days. The project is about entrances and exits to hospitals and how to improve them and make them more staff and patient friendly. And in particular, emergency departments. Initially focused on the Sunshine Coast University Hospital in Queensland, but with the impact of COVID-19 and our reduced ability, or we're prevented from travelling interstate, we've expanded it to include more facilities across Australia and conducting more of the project online. In a way, that's been a benefit because we're going to look at more hospitals and speak to a broader selection of clinicians and other users in hospitals. So the project is about design in healthcare contexts, and it comes back to those aims of the Design Lab and the HEAL project about creating spaces that are more biophilic, salutogenic and eudaimonic. And we're also looking at spaces that can be manipulated and played with so that they can address the needs of future pandemics or anything else that may affect the health system in the future without requiring massive redesign or reconstruction. So the project is at the stage at the moment of we're in the middle of a systematic literature review. We've done our ethics and we've developed a questionnaire, and we're about to start conducting interviews with healthcare staff online in emergency departments and similar places in hospitals. We're going to ask the staff to take for an evaluation of those hospitals, but we're trying to get examples of things that frustrate staff on a daily basis and that could be better designed and so support them to do their jobs better. As I said, this interviews will be online. We were going to do them face-to-face and do visits to various hospitals around the country, in Queensland in particular, but we obviously can't do that anymore. So we're going to have to do this more remotely. The whole point of the exercise is to generate ideas for improving the design of entry and exit areas. They could be small things or they could be bigger things, but they'll all be practical things that could be tried out. And they will reflect some of the issues that are already arising from responses to COVID-19, in particular the need to have larger waiting rooms or to segregate waiting rooms or to bypass waiting rooms altogether direct to isolation facilities. The whole point being that we want to do all of those things to keep people safe and ideally COVID-free or safe from catching it from other people who are already infectious, without also compromising the feel of the environment and keeping it patient-friendly and supportive of staff. And part of that is around access to nature and the aspects of healing environments where we support people in their journey, because it's a very frightening time and people feel very tense and afraid of what's happening in this COVID era. So we look forward to sharing our results with you in the future, and we ask you to stay in touch with us. Here are our contact details, our names and contact details, and the link to the design lab at QUT. We're also really interested in discussing anything with you you may be doing in a similar vein so that we can share our results across countries and internationally. And I thank you all for inviting us to speak today. And I hope that this brief introduction has given you an idea of where we're heading. And I really look forward to sharing with you in the future where we've got to, especially useful things that we've all learnt. Thank you. See you next time. Bye.
I think.
Jonathan, we can see you and hear you.
Okay, good, thank you. Yes, there was a bit of feedback there. Yes.
Just Jane is in the audience if you want to add a comment to
yeah, I'm
the
here.
video. I would say.
Yeah. No, I think we pretty much said it. Actually, our ethics came through today, which was really good. Our amended ethics. For any of those who know what that process is like.
Very good. That's always a major hurdle to get through. My observation, Dave, and to your colleague, that we've moved on from a time when design features. Is that better? Can you all hear me?
Yes.
Yeah, thank you. Yeah, I was just making the observation that there was a time when design features like entrances and exits and how much space there should be between people were kind of nice to have. That's changed now, and these have become very live issues. So the HEAL research, I'm sure, will feed into a lot of ideas about the future design of buildings for healthcare. I think probably at this point it'd be a good idea, given the timing, to move on to our colleagues from Promodel, because they, of course, are involved very heavily in looking to the future and how organizations can adapt and change themselves, very much linked not just to design, but also to systems and processes. So I'll pass over now to Kyle and to Dan. Thank you.
All right, thank you, everybody. Can you hear me okay? Perfect. And if you could see my screen, I'd like to just quickly introduce myself, and I also have Dan Hickman on the line. So here we go.
Sorry, I was muted, Kyle. Good afternoon,
right.
Or good morning, everybody.
So Dan and I work for Promodel Corporation. We're based in the United States. We're here to talk to you a little bit about FutureFlow RX and how we use this simulation platform for decision making during a crisis. There's a quick agenda here. We're going to talk about a little bit more about Promodel. We'll get into digital twin definition, talk about some accurate census predictions and operational and strategic analysis. So again, my name is Kyle Kester. I'm a professional engineer. I've been with Promodel for about 10 years. We do simulation modeling. So we'll show a few of these concepts and what we've done for a lot of our customers in the healthcare space. Dan, you want to give a quick introduction?
Yep, I'm Dan Hickman, Chief Technology Officer at Promodel Corporation, one of the primary architects on the product that we're about to show you, industrial engineer by trade, and looking forward to sharing with you what FutureFlow can do.
So again, thank you everybody for the presentations earlier. We've heard a lot of great things, and one of the things I'd like to do is try to pull some of those together. I heard some concepts around changing in operations, maybe adding in ICUs. I heard things like surge capacity, patient flow. We try to take a lot of that into consideration. And when we talk about a digital twin, the simplest analogy I always give is think about when you're using a Maps app and you're in a place where you don't know how to get around. You know, the digital roads and the virtual roads that you see, if you're trying to get from point A to point B, you'd put in your destination. You know, the Maps app would guide you through, and sometimes we just blindly listen to the directions and trust that it's going to get us where we need to go. Think about FutureFlow being that Maps app for your patients to flow through the hospital. We'll talk a little bit about how we configure this digital twin being a virtual hospital that allows you to test and try any of the strategies and changes that you can anticipate to understand what kind of impact it's going to have on your resources, equipment, or just general patient flow for outcomes as well. With the goal being that just better decisions faster. We understand in a hospital setting that focusing on the patient, and Julie had a great way that she put it earlier about a patient-centric model. That's really how we think of our simulation software as well. We build solutions from the bottom up, from the patient up, so that we could put the focus on the patient in our models so that they act and react as they would in real life, allowing the decision makers to spend more time with their patients and not on all the decision options that they're presented with every day. So very quickly, a little bit about Promodel. You know, I won't read all through this, but we have about 130 direct and indirect employees. We do have some international representation as well. We've been doing healthcare simulation for nearly 30 years. The list of products is up here to the right. I'm going to just briefly show MedModel and Promodel just to show how we've progressed our career through our traditional software, and then really spend the majority of the time focusing on FutureFlow RX. It's our newest platform where we've taken our experience building these custom one-off solutions for hospitals for nearly 30 years, and then incorporating in a lot of our expertise that we've designed around our custom applications that are more web-based, a large number of users, more interactive. We've combined those two platforms to create FutureFlow RX. It's fairly new. We're about 3 years with FutureFlow RX with some development time before that, but we currently are installed at 3 of the top children's hospitals in the United States and getting some great use out of it. So one of the key things that I like to talk about simulation, if you're not that familiar with our brand of simulation, I think in hospital settings, you're more familiar with when customers or when your patients are being, when you have to train new nurses and when you have to train different things. You have the physical simulations where you can work on you know, the dummy dolls and understand how to, where everything is going to be, and you get that familiarity from a physical simulation standpoint. We try to take a similar approach in a virtual world as well. So the reason why discrete event simulation has its benefits, and there's many different approaches, and we understand and we will defer to some of these others when it makes sense. But in a hospital setting, we do feel that because of the increasing variability, whether that's patient arrivals, length of stay, discharge patterns, or it's the interdependencies where there's shared resources, nursing, EVS, oxygen tanks, all those kind of things. Simple Excel models can answer some questions. Monte Carlo simulation, if you've heard that, you know, is great to answer some questions when you have just variability with low interdependencies. You can use statistical models, mathematical algorithms like linear programming to answer some of those other complicated solutions. But it's really the convergence of the interdependencies and the variability that when you get to that complexity, discrete event simulation is the superior, it's superior to mathematical algorithms. And really, one of the things it can do is it can leverage the current state of the hospital. So that's a huge benefit of what we can do in FutureFlow. So I'm going to just quickly show this graphic, but I'm going to jump out of the slides for a second and show it being animated. This is our Promodel, MedModel type application. If you haven't seen this kind of thing, it's like ripping the roof off of your buildings, your hospitals, and we could zoom in. And the most important thing to show here is that we do model every individual patient moving. We can have all the different patient types by their service required. And again, what we've done for years is this type of solution where we come into a hospital setting, we understand what their inputs are, all the floor layouts and space. And I think one of the things that was said earlier in one of the presentations around oxygen tanks, these types of models could be spatially aware, so we can make the paths that patients and resources and oxygen tanks and everything flows through this hospital so that everything moves in relation to speed and distance, and you can have physical constraints. I've worked with a lot of hospitals this past year through COVID where physical distancing has become a very important issue. And we can build those kind of things in these solutions so that you can have the comfortability that, you know, if you install elevator policy changes that only one family can be on, for example, that you're going to have the comfort level that you're not going to have people waiting up or queuing up too much, and you know, changes in simple policies, what kind of impact that's going to have downstream in your process. So I'm going to shift gears and we're going to talk more about FutureFlow at this point. And this is an actual use case that we did for one of our customers. Oops. So FutureFlow is a web-based platform. I think the most important thing is that it's an always ready model. It's connected to whatever systems you have for your electronic health records. And you know, we can receive data every hour, so it's continuously running simulation models and trying to provide more of the operational insights. I'll show you in our dashboard in a moment where we can do +4, 8, 12, 24-hour predictions. But for this example, when we were working with one of the large children's hospitals in Colorado, they're a 5-campus system. What we were trying to do when we initially were contracted to work with them was to help them predict how they're going to get through flu season. We started in last September. We were working very close, and then obviously in the States here in March, everything started to ramp up with COVID, and we shifted gears and we turned this more into a strategic analysis. So this is just a quick view, but it does highlight a lot of different points that we can do and what we've done to analyze during during COVID, but it also, I'll get into a live demonstration of how simple it is to use the tool and how we could use it for things like flu season or any upcoming events that you'd anticipate. So what we're showing here is in all of our tools, we have this what if scenario analysis area. It allows us to play any types of games on the system where we want to evaluate different future states of the hospital. So the example in children's hospitals in the States here were not as impacted, obviously, with the children having COVID. So what they felt they can do is they were trying to develop their emergency and strategic plan to present to the governor on what they can do to alleviate some of the capacity constraints that were anticipated in some of the adult hospitals. So we were able to work with them because they had FutureFlow already installed and we have had all the historical patterns. We were able to quickly spin up a strategic analysis that helped them evaluate, you know, increasing a certain patient type. It also, we were able to target patients under 18, 21, 25, and 30 from all the other hospital systems in and around the state that they were in. And what that allowed them to do was evaluate if they had to take transfers from those hospitals into their system up to certain ages and varying ages, and also from different, like there was a large system that they were evaluating to include or not. We ended up running about 30 different scenarios and we kind of pared it down to a few, but it was what they used to develop their strategic plan and present it to the governor for approval as well. And really in the bottom, what we're showing here is the scenarios that we define and have checked will all show in a side-by-side comparison. So on the chart below, I had to hide the numbers here, what the capacities were, but the purple line at the top is showing capacity over time. The x-axis here is showing what it looked like from March all the way through September. They already knew they were going to open up units, and just like I've heard in some of the previous presentations, some of the ICU, the tents and the things that were put up, if you know you're going to open up beds or feel you need to, we can build that into a model that shows at the correct time when they would open up. And again, the different graphs here, what that's showing is the volume of patients that on top of their demand that they had, which is the baseline at the bottom, we selected some scenarios. We're showing the under 30 and the under 18, and then with and without the One Health system. But what this allowed them to do was just evaluate strategically over time. And it's very hard to plan for the unexpected, but making the assumptions, they felt more confident in the plan and their assumptions that they felt better prepared for what could potentially happen. And the story goes on with them and what we're doing. Once we built confidence in accurate census predictions, we're able to layer in staffing ratios, and I'll show that in a moment. And then also we open the door to doing some PPE analysis as well. As you mentioned in previous presentations here, when policies are changing, or if things are happening where you start to reuse PPE, or if you have a shortage and you have to make some changes, those changes that are made on the fly do have some impacts down the road. And what we can do is show PPE related to census predictions at the unit level or the resource level, and show how a change in policy might impact your on-hand quantity or safety stock and things like that. So at this point, I'm going to shift gears. We're going to get into the tool. I really want to stress just how easy it is to set up a digital twin and show how easy this can be. Just doing a quick time check. So one of the things that we can do in our tools is that we run over time. And one of the benefits to running over time is we could also change some of the historical impacts that we would observe. So for example, what we're showing here is just a few different patterns of how case mix and your service levels. We're going to focus on hospital medicine and critical care. They were the two highest ones in these examples. So what we can do is we could run a model here where this one's running from June to March in the upcoming year to evaluate the different case mix and seasonality service mixes here. So we can have a probability of what a patient would come in if they're going to be in the summer season. We have a summer shoulder respiratory season. And then really the focus of our analysis that we're doing with a customer right now is looking at different flu season options, high, medium, and low, with the expectation that we can adjust all these parameters. And if they want to put in a COVID example as well, we could also redesign their future hospital to have an isolation unit virtually. And it's easy to do that in a matter of minutes. We can redesign the patient flows so that all respiratory illnesses go to that specific isolation unit as well, and really give our hospital customers the confidence that the decisions they're making are going to be impactful and they have plans prepared for it. So at this point, I'm going to get into a quick demonstration. Digital twin, we're going to show the accurate census predictions and then that example. So again, FutureFlow is a web-based platform. We set this up in most of our customers, and really all of our customers, I apologize, right now are set up so that the server is behind their firewall, so there's no compliance issues with data being transferred. We can configure that information, and really what you get is a platform that you could analyze from two different aspects, operationally and strategically. Depending on how big your hospital system is, we can have all the systems in here as well. Again, most of our customers right now are single standalone children's hospitals, with the exception of the one is a 5-hospital system. So we could show in a panel what your entire system looks like. We are talking to some large US systems right now that might have 30 hospitals, or maybe it's a national healthcare system where you might have 80 to 100 or more hospitals. This could be configured so that you see it in that type of view, where you can look at the entire hospital with the ability to quickly filter down to a single hospital and understand all the key important information. So for example, I'll just focus on one card here. If we're looking at our census, every hour we get a data feed from the electronic health record systems, and we can show that at 8 a.m. we had no kidding, 349 patients, that's heads and beds. What we can do in our software is take that, and in a simulation environment, we run many different replications is what we call it. And that's basically just alternative futures. Because there is variability in the patients, we could run many, many times and then understand how the model would predict and show in some of these histograms what the predicted future could look like in terms of census predictions. We have the ability to go to the hospital level. We even have the ability to go down to individual units as well. So that's the quick overview of the dashboard. I'm just going to get through a few quick screens here and then open it up to Dan and others for questions. Really, the definition of the digital twin is we need to come in and understand the size, shape, everything of your hospital. So we can identify all the different units, what the capacities are. If we come down again, I was clicking on this one before, we could look at the PICU and we can input what the beds per staff would be, and we could put the staff ratios in as well. When we go through our retrospective analysis, sometimes we'll take 3 or plus years of a hospital's past data, try to fit that data so we understand, how patients arrive by day of week, by hour of day. We fit your arrival patterns for the different admit sources, typically direct admit, emergent, or OR, but it could be just about any. And then again, I showed the flow classes before on the previous slide. We can make these time dependent as well. So if you have a flu season, or if you wanted to compare how would your hospital react if it was 2017 versus 2018, we can have those different flu seasons installed so you can see what kind of impacts that would have on your hospital. We could do the same thing for discharges. So, the goal of this being we're trying to build confidence for anybody looking at this, that we understand from when the patient admits to when they discharge. We have a very important process of how we determine how patients flow through the hospital as well that I won't go into today. But what we do is we're also fully transparent with our predictions. So just like on the dashboard when we showed the +4, 8, 12, 24 hour type predictions, we also surface that for our customers so they can build confidence. Whatever we predict, just the takeaway from this slide is that we, in full transparency, can show that our hospital digital twin here is predicting accurately within the +4, 8, 12, 24, 36 hours. And you could see, for example, that 80% of our predictions are, it's a demo data set, but this is very well representative of our other customers as well. It's predicting within 1.5 to 2% of the accuracy at the entire system level. And again, we could surface that at the hospital down to the unit level as well. So very similar to what I showed before. If we were looking out and we wanted to look from June to March of next year, and we were looking at flu season, the slide that had the different flu seasons of low, medium, and high, we can quickly customize a tool like this with little effort and show maybe this is what the baseline of the hospital would look like in terms of census for the entire system. I can quickly filter this down to individual hospitals as well. And one thing we often do is we can compare side by side. So you could see if we expect flu season to be very high this year, we start to see that at the capacity for the hospital 2, we're up against the capacity line. One thing we'll do in a lot of our simulation runs is run it unconstrained. And what that means is that if a patient requests a bed or would be preferred to be placed in a bed in that hospital, we don't hold them up. Otherwise, they back up into an ED hold or some type of holding pattern. But we could run it unlimited. It gives you an idea in these tools, what kind of capacity you would require. So this might be helpful if you're trying to size a unit or things like that to understand, how much capacity would be available. And the last thing I'll show is just that again. Yes.
Yeah, I just wanted to let you, we don't have that much time. I think we really want to have some questions at the end, but the last thing, great.
Yep, last thing I'll say here is just, we can layer on all of these scenarios. So like a low, medium, and high flu season, and you could see, I'll go back up to the entire system level. You could see how they kind of navigate through each other here, and you can get a sense of where your capacity is going to be. If we look at the staff types, for example, this is where we are with one of our customers. We're trying to help them evaluate what their strategy is for resource planning for next year, and do they need to, is it overtime, is it travelers, is it what type of nursing and resource strategy do they need to employ? And because we have the staff ratios and we have accurate census predictions, we could relate those to nurse staffing, for example. So I'll leave it there. I know I appreciate everybody's time. We're open to discuss this further, or if you have any questions or would request a simple demonstration, feel free to reach out to me. Happy to do this, and anything we could do to enhance the patient outcomes in healthcare is our goal. Thank you very much for your time.
Thank you so much, Kyle. Thank you, Dan. I know you're there in the background as well.
Yeah, no problem.
Yeah. Listen, fascinating presentation, and I'm going to use kind of chair's privilege here to ask my first question.
Okay.
You gave examples there from flu season, which is of course really important to hospital organisations. It's a major issue every winter in different parts of the world. To what extent do you think you could adapt what you've got to look at very rapidly, I mean, of course I'm thinking about COVID here, but very rapidly emerging situations where the pathology of the disease is not so well understood, and you can't be sure when you're going to see peaks and drops in demand?
Yeah, we went through this with some of our children's hospital customers, and we don't know exactly how it's going to react, how long patients are going to stay, but what our tool gives them the capability to do is adjust what those potentials could be. If it's as severe as they expect, they could adjust their patient routing so that patients stay longer. And we could isolate. We did this exactly where we created an isolation unit. We were able to quickly configure patients that have a certain diagnosis to go to that isolation unit, and understand that if they make policy decisions, what kind of impact is that going to have on their census, their staffing, their PPE in a tool like this.
I'll jump in there and add a little bit too. So of course we have limited time, but the key to our model is capturing all those different system dynamics that exist in real hospital operations. And I always say there's the big three, and your question falls right in line with the big three. It's, how do you drive the demand that's going to go into the hospital, which the demand would be representative of how many per day, when they arrive per day, and then who are they creating when they go in. And so like Kyle said, we're with the COVID flu scenario that we've been working with, we didn't know what those peaks and valleys would be. So what we did is we worked with the very intelligent people at the hospital. We looked at 2019, we looked at 2018, and we just, we had a tool that could take 10 different versions of that with that institutional knowledge and say, well, I'm Dan, right? Dan had an idea. Well, I think it's going to look like this. And Jonathan, he thinks it's going to look like this. Well, let's play that out. Let's see all the different combinations of how this, we demoed it as a high, medium, low, but in reality, at the real use case, there was much more than 3 different versions of what the future might look like. Yeah. So we just needed the ability to plug that in and see how it would play out, but representative of real flow, real dynamics, real length of stay, it's historically driven. So hopefully that helps.
Fantastic. Yeah, it does. Thank you very much. Listen, we're just about at the point where we have to end, so I'll say goodbye to both of you, and thank you again. Fascinating presentation, much appreciated. I think we're going to put up a slide now which will give you the flyer for the next presentation, next webinar, which is going to be on October the 16th, and you can see there that the topic is space systems and technology for the new normal. So we've moved on from staffing, and we're looking now at space and systems, and then eventually we're going to have a look at supply chains as well. So everyone who's been here today, please book your place already if you can. Think about it. Make sure you keep the date for that. Mika, are we going to try for one of the questions? Yes, we've got the Mentimeter there. We would love to have your feedback on how things went today. I think we'll leave the third Mentimeter question, which was around what questions we should address in the next webinars. We can perhaps get some feedback directly from you when we email out to you the links to the presentations and the and indeed the recording of today's event. So while we're just letting that run for a minute or two, Mika, is there anything you'd like to add?
Not at this moment, no. I think it was a very, like last time, a very varied and very interesting mix of different examples. There were a couple of questions about the project. Do we have a website or a social media account? The answer to both is not yet, so we will come out with that later this fall. And I think by the next webinar on October 16th, we will be able to communicate more details on that matter.
Okay, right. Mentimeter seems to become a little bit stable now, so I think perhaps on behalf of everyone involved from Ramboll, walkerproject, White arkitekter, and EuHPN, we should thank our speakers for huge efforts they put in, often at short notice, certainly in the case of our colleagues in Australia, who also had to endure a webinar quite late into the evening for them. So much appreciated. And we hope to see you next time in October on the 16th. Thank you all. I think we'll end it there.
Thank you.